I'd like to welcome my panel to the stage now. If I could have Sarah Klebold and Derek Harris from Arrow Senior Living, and also Lucas Donnelly from EmpowerMe. We're going to have a conversation about the GUIDE program. And if you're not familiar, GUIDE stands for Guiding an Improved Dementia Experience. You know, one thing that I like to call out is, one strategy isn't going to get it done here. We need to try multiple things. We need to put multiple initiatives in place to really get value-based care going in our communities. And that's what we're going to talk about today. Welcome.
Thank you.
Yes, sir. First, let's start off and just do some introductions and tell us about your organization. Derek, can I start with you here?
Yeah, hey everyone, I'm Derek Harris. I'm with Arrow Senior Living Management. We're based in St. Charles, Missouri. We manage just close to 40 communities, independent living, assisted living, and memory care.
Wonderful, thank you. And Sarah, you're also with Arrow Senior Living?
Yes, I am. I'm the Chief Legal and Administrative Officer. I wear lots of hats, so primarily general counsel, but I do have the great pleasure of working a lot with Derek on a lot of our wellness initiatives, including value-based care.
I love the passion coming from the Arrow team, absolutely. And Lucas Donnelly from EmpowerMe Wellness.
Hey everybody, Lucas Donnelly, Chief Strategy Officer at EmpowerMe Wellness. We serve just over 1,000 senior living communities with our daily on-site teams. We got about 4,000 therapists in the field. They deliver outpatient therapy. We own a long-term care pharmacy, so they help connect dots there as well. And over the last 3 years, we've developed a care coordination model that built a centralized medical group and trained our therapists to be the eyes and ears in the community and a dotted line extension of the director of wellness. So that's really taken off, have over 10,000 seniors participating in these care management programs, one of them being GUIDE.
That's great. Thanks, Lucas. So I got to say, last year, I think I was at the VBC conference and somebody said to me, do you know about the GUIDE program? And I was like, what are you talking about? What is GUIDE? Because it feel like it hit us really fast and some people are running with it, some people aren't. But what is GUIDE, Derek?
So as Lucas was saying, we had I guess you could say luxury of already having principal care management rolled out in our communities. So that's a care coordination service that EmpowerMe provides. And when we started looking at GUIDE, honestly, we didn't know that much about it because it was brand new. They were early access to it. We started last year and we've been building it up over time. But really at its core, it is care coordination. But one of the things that I like to think about, though, is everyone's talking about resident focused, but this is also looking at what's important to the community. So whether that's the wellness directors, whether that's the nurses working in the community, or also the families, we can't forget about them either. It's looking at literally everyone. What does that resident need? And what do their loved ones and our staff, what do they need as well? So there's really nothing that's written out saying this is what you have to do with GUIDE. Well, technically CMS does have rules, but as far as how we implement it, it really depends. Does this resident need just restorative fitness? Do they have a lot of complex medical needs that requires enhanced care coordination? Do they need help with just family communication? There's just a multitude of things that can happen, and it also helps to relieve a lot of the efforts that our staff put forth. I don't know if that was a brief explanation.
No, that was perfect. And I will say, so when you talk about our residents, the GUIDE program is specifically pointed at residents who have cognitive decline and from our perspective are living in a locked dementia unit or receiving respite, correct?
It could be anyone with dementia.
Oh, so it can be?
Yeah,
okay.
Living at home, IL, AL, memory care. Yeah.
Cool. So I got some misinformation on the locked unit there. So Lucas, I'll pass it over to you now. So from the healthcare provider perspective, what is the GUIDE program, if you could?
Yeah, zooming out a bit. So Center for Medicare and Medicaid Innovation launched this program. It's an 8-year program with 2 years of runoff. So technically, it'll end in 2034. And what they realized was there's just a massive cost to the system, not only just for serving residents with dementia, but their families. and they were trying to calculate the burden that comes onto the system. And there really isn't a care management program in place that's specifically designed to serve seniors with dementia. So they created this program. It launched initially in 2024. So there's 100 organizations that launched in 2024, July of 2024, on the established track. We were part of the established track. The main goals of the program, 5 goals, if I can get this right: reduce total cost of care, increase quality of life, reduce utilization of high-risk medications. The last one, I'm forgetting the 4th one. The last one is caregiver burden. So they've created a respite benefit where they're providing just over $2,500 a year to relieve the caregiver burden, where there's, if you talk to any of your residents with, who have family members that are in the building visiting, it's overwhelming. So there's a really unique opportunity to deliver respite that actually falls outside of total cost of care, which is an attractive feature as well.
That's great. Sarah, would you add anything from a definition perspective to guide from a legal and risk perspective?
Not from a legal risk perspective, but I think it's important for everyone to understand what a great opportunity this is, because they are putting out lists of everyone with the dementia diagnoses. So think about that from sales perspective, not only just perspectives, but people within your communities. And so it's targeted just for this specific thing. So for all of those people that are in their early stages of value-based care or mid stages, it's broadening up maybe another level of resident that we haven't been able to focus on before.
That's great. Thank you. So going back to I would like to be in the room where the decision was made to take 30 to 50 of our most complex residents and put them into a locked unit. Who was yeah, this is a good idea.
I remember the 4th benefit is reduce utilization of SNF.
Oh, okay.
Yeah.
So. Very good. Very good. And I love the sniff skipping on the cognitive side too. But back to the kind of the demands of real-time service coordination in a memory care unit. It was my favorite place to hang out when I was operating communities, because the service coordination had to be real-time, right? They're complex. You're only as good as the moment that you're in. And the staff there had to have a lot of tools in their toolkit in order to help those residents live moment to moment successfully. Lucas, what does the guide program mean for memory care operations from your perspective? And can you maybe talk through what's the process a person goes through when they're a part of the guide program?
Yeah, maybe not just memory care, but broadly, any qualified senior in the program. And this is what I think is unique about the program. CMMI has given a lot of leeway to guide participants. They've given us the guardrails, and it's our job to build an interdisciplinary care team and a personalized care plan focused on the senior. So if you've talked to one guide participant, you've talked to one guide participant, and everyone has a different way that they want to tackle their residents and serve them best. So that's, I think, important to clarify. The guardrails, they've given us the respite benefit, and there's also 9 care delivery services. Anything from care coordination, comprehensive assessments, respite, transitional care management, and so on. So those are the rules. Those are the services that have to be provided as part of the program, and it's on the participant to deliver that in the best way for the resident to accomplish those 5 goals that we established. So what does that look like for us? We, like I mentioned, we've got a team of 3 to 5 therapists that are there every day. They see them as part of therapy. They eat with them at the same table. They know their family members. They're very highly qualified to be care coordinators. So we trained all 4,000 of them. We've equipped them with a medical group that sits centrally. So we've got a team of physicians, nurse practitioners, nurses, care navigators. And we've embedded that role. So we have a clinic director, kind of a champion, as we were talking about in this last panel, so important. That clinic director effectively reports to the director of wellness. And the question of the director of wellness is, if you had an extra hour to sit down with this resident this month, how would you spend it? It can be as simple as home exercise programs. Let's say they got discharged from therapy. So this person, or speech therapy, very commonly with someone with dementia, let's spend an extra hour with them to make sure they're staying in shape. It's holding an iPad. So the director of wellness doesn't have time for that. We will hold the iPad, facilitate a telehealth appointment, and get them the specialty care that they need, or utilizing e-consult services. And the goal really is to give the DOW more time to do what they're making the biggest impact. The other very popular use case is us waiting on hold with physicians in hospitals. So we're the people that wait on hold so that they can go serve more residents. How does a senior get enrolled? Residents undergo what's called a comprehensive assessment. So it's a series of assessments that stages the severity of their dementia. So that determines kind of the care plan.
And you facilitate this assessment process.
We facilitate this. We'll talk in a little bit about ways that we've involved the operator as well. We complete a Zaret burden interview, which that looks at the caregiver burden and how heavy that is and what the care plan needs to be. And then our medical group will formalize a care plan with the director of wellness. So we're on the same exact page as the DOW on what the plan of attack is going to be to serve the senior with dementia.
I love it. That's amazing. Sounds pretty person-centered.
I agree.
Yeah, absolutely. Sarah, this program is designed to support better outcomes for residents and caregivers. What has Guide done for Arrow from your perspective? And I know it's been a short period of time, but what are you seeing early on?
I'll talk a little bit more about like from the risk side, and I'll let Derek talk from the benefits. But everyone here knows we are in a high risk industry. You have falls, you have elopements, you have medication errors, you have resident to resident issues, especially in memory care. And so when you have an opportunity to have more touch points with residents on a monthly basis, or a dedicated team that is freeing up time for your staff, you're going to see benefits from that. And I rode in the Uber with Lucas yesterday, and he shared some data with me. But our communities who are on Guide, but I do think it speaks to value-based care in general and some of the other initiatives that we have. But we have 32% fewer falls compared to the national average, and 43% fewer visits to the emergency room. So that's some of the benefits that I think value-based care and Guide can offer from these touch points, and just paying a little bit more attention. So he talked about reducing the number of medications that someone's on. So certain types of medications may be more likely to lead to falls, or the more medications you have, the more likelihood of a med error. When you have these people regularly visiting with the residents, I think you can pick up on some behavioral changes. So are they going to be more inclined to elope or have a resident-to-resident issue? So those are all things that I think are helping our team in general, and to help reduce kind of incidents and litigation.
That's great. Derek, operationally, what are you seeing early on across your staff and resident experience? And also maybe what was the lift to bring the program in operationally, if any?
So to kind of echo or add to what Lucas was saying as far as how this went, or some of the things that we're experiencing in the community, I think probably my favorite thing is times that we're actually supplementing the care, whether that's something that our nurses would do or the wellness director would do. And this would be unique to each operator and to whoever your Guide provider is, because you might have certain rules on that. But say if a resident falls, and let's say if you've got the Guide provider in the community when that fall occurred, that's someone that can assist with. In our communities, we've got fall management systems, so they could review the footage. They can help us come up with a post-action review and interventions and just things like that. And who else is going to do that? Well, of course, our wellness director is still going to review the footage on their own. They're still going to maybe add in if there's any other interventions that they could add, but it still is essentially helping to take away some of that time. Or, as Lucas was saying, the waiting on the phone. So if we want to call the pharmacy and ask for them to do a medication review for that resident, say in the example of the fall. So there's so many things that this can do, and I just wanted to echo the fact that while CMS does have rules, we have a lot of ability to interpret this and make it work for our operation. And to get to the second part of your question, Murray, that actually made it kind of easy to roll out because we weren't just meeting someone else's rules 100%. We were actually able to take what Guide is able to do. We were able to compare that to an existing process. And then it just really came down to the education. And similar to rolling out principal care management, when rolling out Guide, we found that the best thing was to be able to share success stories with the teams. What's in it for you, or what's in it for me, the WIFM. The staff, it's not that they don't care about the explanation of what Guide is. They want to know, how will this help me? What changes will I see in my day-to-day workflow? And that's what really works well for them. And then also leaning on the providers. So having family nights and having the opportunity for them to hear about the program and ask questions. And it also really helped with the fact that the Guide provider is someone who, in some cases, has already been contracted with the community for several years. So it's not a new face. It's someone that they're used to. It's a company that they're used to.
That's great. Thanks for sharing. I just want to check in with my coaches over there to see if any questions came in or if there's any commentary from the peanut gallery over there.
Yeah, we had one. I mean, it's been a great discussion around who's eligible in the building, what those benefits are to the resident and the family. I guess the one question that just to, wordsmith it a little bit is, how does the partnership work between EmpowerMe and the operator? So we're clear that EmpowerMe is now the CMMI Guide participant, but not just from the money perspective, but from the care and how does the funds flow work? How does the partnership work, if you don't mind sharing, between CMS to EmpowerMe to Arrow, and then the output is glorious?
Yeah, right. It's again, pretty unique because they've given this partner organization framework. So we build this interdisciplinary care team. Some operators want to be very, very involved and be part of the care delivery. Some operators say, I'm overwhelmed. Please, any help we can get, you guys take this and give us the reports and the success stories, and we'll advocate for you. So it really depends on the operator. We'll talk about respite in a little bit, but that's one benefit that operators can utilize today. There's a $313 a day respite benefit that can be utilized that has been, kind of interestingly not utilized very, very highly. But it depends. So the care delivery services that the partner organization, signs up for, the only way we can add folks to that care team is if they deliver some of those services. So sometimes the operator will help us with assessments and get compensated for assessments. Other times it's actually utilizing their labor, but that has had probably the least amount of participation and kind of uplift, because I think the general takeaway that we've had is they're like, hey, we want you to take this off of our plate. We don't want you to give us more work to do.
I see. Well, thank you, and thank you for who asked the question.
Yeah, very good. And getting into that kind of respite part of the conversation, this program has overall respite benefits. So, be it our staff or the spouses of the residents, the family members, can you talk a little bit, Sarah, and open it up about the benefit there?
Yeah, when I first heard about Guide, I was really excited about this benefit because I think it's super unique. So there's a couple of components. There's an at-home component. So again, this program touches more people than are in our community. So maybe not for us, but if you have a home health company or home health company, that could be helpful of getting some care for a potential resident at home. To give the caregiver some time away. But then there's an 8-hour a day respite service that when I thought of that, I thought of, we have campus, so you have a lot of people in IL or villas where you have maybe the husband is still the primary caretaker and the wife has dementia. How could he also benefit by maybe having the wife come over to the memory care neighborhood for, a day so he can do some activities on himself, and that relieves him of some of the burden. And then you just have the respite stay. So I was really excited about that, but we chose for our purposes to kind of start with the care coordination because it was aligned with what we were already doing. It was, an easy lift for us. So we have not really taken advantage of the respite yet. It's something that we're looking to do kind of this year to focus on, but it does take some thought into it. Just from my perspective, while I'm not in favor of kind of federal regulations, I think the fact that we are all regulated by the states and every state is different, that makes it super complicated because we all have different licenses and different regulations of what we can and can't do. So, can you bring someone over from IL to your memory care if you don't have any of their health records? Like, how are you doing that? Are you staffed for that? What liability are you taking on? Do you have the ability to protect your residents that are currently there? So there's kind of that component. But I think, the respite benefit for bringing people in, it could be utilized as a great sales technique to allow people to come into the community and try it out for a few days, or they start and maybe you can find some sort of concession or something like that and help them transfer over there. So I think there's a ton of opportunity there. If anyone is using it, I'd love to brainstorm. Derek and I are going to put our heads together on how we can better utilize it. But I think it's a fantastic benefit, not just for the resident, but for the caregiver.
So to really just double down on that one, so what you're saying is that because the guide program, which in most other instances across the country is for a homebound eligible, you're saying that an assisted living or a memory care could actually be contracted in which for the guide participating practice, in this case EmpowerMe, if they were serving a resident in community or an IL that needed to leverage that benefit, that resident could come into the assisted living or memory care and be funded as such through this program for a number of days.
Yeah, there's a cap on the amount of
yeah, and
yes.
It's acted as a great feeder.
Yeah.
And
yeah.
Can I add something to the conversation? And Derek, can I put you on the spot, man?
Sure.
I appreciate you. Thank you. So sometimes when we get in like management meetings, we talk about like an issue and we like talk all around this issue and you hear all these different opinions and all these different nuances to the thing. And then sometimes I get in a meeting, I'm like, so what are we talking about again? Like, simplify it for me. So my question is, and so this is a common practice I do in meetings when my denseness gets in the middle of a situation. And you guys are, first of all, doing a wonderful job of unpacking this for us, right? But this is a thing, like, I'm still like, guide, and I want you to talk to me or like look out in the audience of like to an operator. I'm like, Derek, use common language for me. What is guide and why are you doing that?
So guide is basically care coordination, and that's got a very, very broad definition. So think about it this way. You've got a resident that has a dementia diagnosis. What do they need? What's important to the resident? What's important to their family? And then for the care team, what would help the care team provide better care? What would help our community have a better satisfaction rating with the family? Maybe it's communication. Maybe it's the fact that the resident has behavioral issues that we haven't been able to work through. Maybe they use a outside medical provider, not the contracted ACO. And by the way, they've got 4 specialists that they're also going out to see. So what is going on with that person? And then what could we do to make it better? And then you have a lot of flexibility to figure out, okay, what will it take? And then that's kind of the beauty in it, because you're putting your head together and it's collaborative in the sense that it would be this clinic director and they're collaborating with the wellness director or with various service areas in the community. They're talking to the primary care. They're reaching out to the specialists. They're talking to the pharmacy. The challenge is it is just so immense what they can do. So it's hard to put it into just kind of like a short and sweet and tight
Would you say
definition.
Would you say it's giving you time? They're essentially giving you time to do the things you need for the individual that has dementia care needs.
Well, yeah. So, think it's a community that, say, assisted living and memory care. Let's say there's 90 apartments and you're full. and there's one wellness director for that community. And do they have an hour or more every single month to dedicate time? And the chances are they don't. They have to rotate that time.
Yeah, it's time. Absolutely. Lucas, anything you'd add over there?
Hey, and I want to say
Yeah.
thanks to Derek. Like,
Does that make sense,
That makes
Andy?
a lot of sense.
Do you need
And-
more time to take care of your...
And I appreciate you letting me put on the spot, and that provided a lot of clarity for me. And if I pare it back even simpler, it's care coordination, care management. You're bringing in EmpowerMe to power that, bringing more resources to your community to help manage the medical complexity of your people,
Got it.
of those residents you serve. Yeah.
Bam.
Yeah.
Print it.
Important.
Thank you.
Important
Good job,
point.
Derek.
Working with, if the guide participant is not the PCP, a required member of the interdisciplinary team is the PCP. So I think a pretty important distinction is that we work very closely with all of Arrow's PCPs just across the entire portfolio and keep them in the loop. So it's very important to like not step on toes, but we're there every single day. So the DOW doesn't call us. They walk over to us and they go into our clinic and say, hey, we got to get Miss Betty into this specialty appointment. Can you hold the iPad for this specialist visit? It's that type of practicality where we say, all right, let me call the PCP, get them in the loop so that they know what's going on and they can be there and intervene in the very unique ways that they need to intervene when they're in the building.
And anybody who has managed a memory care resident's needs knows how many times you're calling their PCP. It is a lot.
There's a lot going on.
It's a lot of time. 2 points before we get into the questions. First one is, I think we've done a really good job over the last 2 days thinking about the intrinsic value of these programs beyond the monetary return of the contract, right? Understanding how all this impacts length of stay, resident engagement, staff's time, attrition, turnover, occupancy. And so I encourage you to think about how, on question 3 specifically, how the guide program might impact those operational KPIs. And the second thing I would just mention real quick before maybe turn it over to Al, I think's over there in the wings, Coach Al, is independent living. Like, we haven't really spent much time about the expansion of healthcare coordination down the continuum, but it's happening. There's probably people in this room that have healthcare concierges for their IL residents when they do need to get to their provider or have to go to the hospital. And I don't want to forget that group as we talked about the respite care component. Coach Al.
All right, so we are moving into the home stretch here, guys. So we got a 20-minute breakout. Again, let's stay engaged. We're almost to lunch, but we got 20-minute breakout, and then we'll do an integration. So
We are glad you're here.
How'd the conversation go? Tell us about it.
We had a really great conversation. I think I was saying what I love about the program is also what's hard about the program is it's very flexible. Like you build your care team, you build your strategy, you build your care plan for each resident, and then we have a lot of leeway on how we care for those seniors. So we talked about the respite benefit quite a bit, how it can be utilized. It's been, in my opinion, pretty underutilized by senior living operators. Private duty agencies, home care agencies, home health agencies all use it, but less so on the operator side, and for some of the complexities that Sarah talked about. So we talked about some use cases for that. We talked about engaging prospects with the guide program. So that's something that we've been doing is training a sales team member at the operator to reach out to their prospects if they tour the building and they want like a watermark light, like experience what it's like to have this level of care coordination, and then you kind of stamp your name on that prospect. They're not going to move anywhere else because you've been able to help them so much. And then we talked just a little bit more about kind of the dynamics of how we're actually spending time, what those touch points look like. So
Can I ask you, I got the question, you mentioned deploying therapists into the building, speech, OT, PT, behavioral, what kind of therapists are you deploying?
PT, OT, and speech.
Okay.
Yep. So we don't have behavioral health therapists. Typically, that's a great example of like referring, if there's a medical group that does provide behavioral health and we do our touch point, we do multiple touch points a month, and we see that decline, we reach out to the DOW, say, hey, are you seeing the same thing? And if so, we'll reach out to the PCP and let them know, and then they'll execute on behavioral health. So we don't need to do everything, and don't necessarily want to do all those
That
things.
is way underutilized behavioral health
Yeah.
for therapists in a memory care environment. Just because they've got cognitive decline, they still need to talk about what's going on in the world.
Maybe our top two referrals, aside from like routine referrals, would be behavioral health or Jerry Psych. So Jerry Psych takes, 6-7 weeks to get in person. We collect the prescription data. We, understand what's going on with the resident. We reach out to the PCP, and then we get an e-consult is typically what happens with the guide population, where they can get us med recommendations within 24 hours, send that to the PCP, and make the med changes.
Derek or Sarah, the question I have is, when you look at guide, are you implementing that in kind of the sales approach, and are you using it from a sales perspective with prospects? Is that something you've thought about, or are you doing that today?
We're not super heavy with it. We did some education when we first started rolling out the program, and we have had touch points since then. I was actually talking to someone on Lucas's team and acknowledging that that is something that we need to pick up on and make sure, because unfortunately sometimes sales team members, they will turn over, or we've had new communities open up. So they're not always getting that exact same orientation, but that is something that I would recommend. I can't say this because I'm doing it, but I'm saying it because it is on my to-do list for when I'm home, is make this more of a standing item. Just make sure it's something that's covered as far as, we have standing calls every single week with all of our sales teams, since we have EmpowerMe in every community except for one, but it'll be 100% soon. That's something we could just have them join and just make sure that's being covered on a standing cadence.
I think two things stuck out from the two tables that I spoke to is most people hadn't heard of Guide. And so I'm pretty sure probably most of you guys hadn't. And so I encouraged them, if you guys are working with provider groups, or, we work with EmpowerMe, but ask who you're currently working with to see if they are a Guide provider. It is a newer program, and a lot of people were not able to start until somewhat recently, but I think there's a lot of benefit there. And so start with kind of maybe who you're currently using as a resource, or do they know someone that is a Guide provider that you guys can work with? And then we also spent a lot of time talking about respite, because I do think it's an exciting opportunity and a huge opportunity, but please be intentional and deliberate about it. I don't think you can just, have people come in for respite without a plan. It is a lot of education with your sales team about what it is, how you can utilize it. And then again, you want to set, both the resident up for success and the family. And if you're not going through a very kind of structured sales process to where when they come in for the stay, that they're going to be successful, you're kind of missing the point of that.
Could I piggyback on one point as well? So one of the tables over here, we were talking about just the overall complexity about Guide, and what we were saying, there's so many different things that could be done for the resident. It's not black and white. It's not really a short answer. Or if it is a short answer, it's way too vague to where it doesn't really make sense. So the recommendation I have, and a side question that came up, is we didn't have to worry about everybody offering Guide when we first started doing it, because it was limited to very, very few people were able to do it. Now, every community probably has 2 or 3 providers that could be providing Guide to you. I would say if I were in your shoes, I would just figure out, what do those Guide providers offer? They're probably not going to do the exact same thing. Ours are very ingrained in our day-to-day operation. Others most likely are not. And there's no right or wrong way of whether they are ingrained or not, but find out what works for you then. So you know what your potential Guide providers can do, what do you want them to do, and then find that alignment between the two would be my recommendation.
Love that. If, as the Guide participant, the couple of things that I would ask people that you're talking to: some of the program requirements, one are these touch points. So it's typically 1 to 2 touch points a month that's required. It can be done on FaceTime. It can be done on the phone, or it can be done in person. So ask these participants, what is the nature of those touch points? Like, how are you structuring those? Are you just calling once a month? What's the content? What's going on during those touch points? Because that's very important. It can just be like hey, how you doing? You're doing good? Cool. And hang up. That counts. But that's not going to drive any results, right? So I would just ask them, like, how are you structuring your interactions with the people participating in Guide? The second thing is, which I think really supports the SNF, reduction in SNF goal and the reduction in hospitalization. So Sarah talked about our emergency department utilization per 1,000 resident days is 43% below national average at Arrow, because we've changed the behavior at the community level so that they call our 24/7 support line, or even better, they walk across the hall and tell their care coordinator that they spotted something. So how does that change behaviors? It allows us to call the PCP, get a plan together, determine, oftentimes it's antibiotics, or, it's oftentimes they just want to hit the risk transfer button and call 911. And we are able to prevent that quite a bit by just changing that behavior at the community level. The rest we try to do kind of to enhance and not replace a lot of things. So I would just recommend asking about those two kind of workflows, because that's what'll, in my view, drive a lot of the results.
Hey, we've got a couple questions that came in from the QR code, and some of these are kind of technical, and I think that they're really insightful just around how this actually works in reality. So one question was, if a resident is participating in the Guide program, does that impact their eligibility to be part of an ACO or a REACH or some other, outcomes-based program?
Short answer is no. So they can still participate in an ACO. There can only be one Guide participant. And I had a question at dinner last night. Another provider, let's say the PCP, can continue billing for chronic care management, for example. They can continue doing exactly what they were doing. We can't. So there's like an exclusion list that a lot of people have been confused by. That's considered double dipping from our side if we were going to do all these other things. So that's the clarification.
Yeah, I also just want to pause and appreciate the evolvement of our conversation as it relates to value-based care. I think this session particularly, the Part B session earlier, Joelle made the comment to me. She kind of leaned over to me. She's like, that's the most technical value-based care conversation that we've had. And I had the opportunity to see Jason Fuhrman here just a little bit ago, who was in the Hall of Fame, that we gave the Hall of Fame to, and big payer experience with LTC ACO for multiple decades. And he's like, I was way more impressed with this audience than I thought I would be. And they are further down the road of very, very, very skilled institutions. He goes, in many ways, this group is more skilled in navigating some of this complexity. So I'm really just wanted to pause and appreciate that we're not talking about, hey, get access to your data, or hey, get primary care involved in your communities, right? That's kind of an early move. But this is getting real technical of codes, and some of y'all might be a little bit lost on that. But a lot of us are trying to learn and lean into this. I'm really appreciating you guys inviting us into that.
Yeah, Andy, I agree. We're past college. We're in the pros now.
There
right,
you go.
Coach?
Well, we're quite in a pro. Maybe we're past high school, right? We're into college. Let's go there.
Although, shameless plug for the upcoming session where we are going to talk about getting access to your data.
I just hope that Tim's bar wasn't so low, right, that we didn't have much to exceed his expectations. But no, that's great. And I obviously agree. I mean, we have really come a long way, for sure. Sure.
Are you all open to taking one more question? I know we've got about 4. So this one, it's actually, even I am curious about this, because every time I think I understand Guide, I hear something, I'm like, oh, maybe I don't know this as well as I think I do. What is the process for signing residents up for the program? And how does that work? And I think we got to hit on the two important E words in this one, and that's eligibility and enrollment. And then I guess my more technical question, Lucas, is this a voluntary alignment? I didn't think so. So yeah, help us understand.
Yeah, happy to. So first on eligibility. So this is only a program for seniors with traditional Medicare. So MA plans do not qualify or participate. My hope is that they'll evolve and develop similar models, but that's not the case. So traditional Medicare, they cannot be a resident of a long-term SNF stay. So, and that's judged by 100 days or greater. So it has to, we're just not focused on SNF. None of our portfolio is SNF, but they're, they can't be in SNF. They cannot be on hospice, and they must be enrolled in Medicare Part A and B, which is, the vast majority of your residents will be enrolled. So that's kind of the eligibility component. And I guess the fifth, that's kind of obvious, they have to have dementia. So if they don't have a qualified dementia diagnosis, then the guide participant, the provider, is required to complete that diagnosis either with their PCP or if they're qualified on their own. So those are the 5 eligibility steps. What does the enrollment process look like? From a practical standpoint, the communities will typically host a family night, or they know who has dementia because you start with your memory care and your AL, and then you even IL residents, believe it or not, many are in the program. So typically we'll host education sessions, provide some information. Either we will, because we already have a relationship with them, and many of the other guide participants will too. It's not like a brand new relationship. So you tell them about the program. There's no copay. You have, for qualified folks, there's almost $2,600 of respite to utilize with, it's 75 hours of private duty or 8 days of assisted living. They sign up. You run that eligibility. Then there's the comprehensive assessment, which is a number of assessments. If they don't have the dementia diagnosis, you diagnose. If they do, you skip to the next step. You stage the dementia to see how severe the dementia is. It's a fast assessment. It's fairly simple, but that's the standard assessment that we need to do. If they have a caregiver, you complete the Zaret burden interview to see how severe the caregiver burden is, and that judges whether they qualify for respite. And then you collect a few other details like their PCP info. You collect their med list, since that's one of the goals. The whole process takes, depending on the resident and how chatty the family are, because honestly, Zaret burden interviews have been the most intense part of this process. Is they just emotionally asking them these questions is intense. So it takes about an hour to an hour and a half. We then submit those results to Medicare, and you know how efficient the government is. It takes like 14 days for them to respond and say, yes, they're enrolled in the program. This is their severity. They kind of confirm that information.
Thank you so much. That was like the clearest, most linear explanation of guide eligibility and enrollment, and then ultimate, acceptance into the program that I've heard. So I appreciate it. And I think, you hit on something that's super important here, and that is so much of when we talk about healthcare, we're focused on our higher acute residents, primarily in assisted living and memory care. But when you look at a lot of the demographics and diagnoses of our folks that are living in independent living, they're very similar to those that we serve in assisted living and in memory care as well. And so I get excited about the idea of programs like Guide and another session that we're going to have later today talking about a few different models in care management, because these are now offerings that as an independent living operator, I can say in my, sales and marketing material, hey, I am not providing these care services to you because that would make me assisted living, but I have a partner who's going to provide all these awesome care coordination services to you. And, one, that's an awesome sales and marketing technique, but two, now I can go to Lucas and say, okay, Lucas, you're providing services to a few of my independent living residents that need these care coordination. You now have information to help me have the conversation with them and their family on when it's the right time to make that transition to assisted living. It's a data-driven discussion now. It's not this resident keeps complaining about you wandering in the hallways, which we all know that the number one reason, residents are the first ones to tattletale on who they think belongs somewhere else. So
I was going to ask that. Do you pass that information from that hour-and-a-half assessment back, or are you in the room when that happens?
Oh, yeah. So they're typically not in the room. Again, we're trying to take time off their plate. So we package that all together and share the care plan with the operator. I think that's probably something I should have said earlier, is like, hey, you're part of the care team. What are we doing to tackle? We get a lot of complaints, sometimes it's misplaced, and we try to channel that as well. It's like, hey, that's not really the case, and the care plan changes for IL, right? If it's an IL resident, it's like cognitive therapies that maybe you wouldn't bill Medicare for, but like games and companionship and making sure their meds are, because they're taking their own medication, so we're helping them with that. So it depends. It's the care plan changes over time.
That's great. Thank you. I mean, very, very informative. Let's give our panel a round of applause here, and thank you all very, very much.